Hello everyone. Today I am going to speak about a chest pain or acute myocardial infarction. So, what is myocardial infarction? Myocardial infarction is usually occurs when coronary blood flow decreases abruptly after a thrombotic occlusion of a coronary artery previously affected by atherosclerosis. Acute coronary syndrome, and specifically myocardial infarction, is most commonly caused by an imbalance between oxygen supply and oxygen demand, resulting from a partially occluding thrombus forming on disrupted atherothrombotic coronary plaque or on eroded coronary artery endothelium. Severe ischemia or myocardial necrosis may occur consequent to the reduction of coronary blood flow caused by the thrombus and downstream embolization of platelet aggregates and or atherosclerotic debris. So it is nothing but impairment of supply of oxygen which leads to necrosis. The amount of myocardial damage caused by coronary occlusion depends on the territory supplied by the affected vessel, whether or not the vessel becomes totally occluded, the duration of coronary occlusion, the quantity of blood supplied by collateral vessels to the affected tissue, the demand for oxygen of the myocardium whose blood supply has been suddenly limited, endogenous factors that can produce early spontaneous lysis of the occlusive thrombus, adequacy of myocardial perfusion in the infarct zone when flow is restored in the occluded epicardial coronary artery. Actually, how clinical presentation of myocardial infarction? The clinical presentations in up to one half of cases, specific precipitating factor appears to be present before MI, such as vigorous physical exercise, emotional stress, medical or surgical illness. Although MI may commence at the time of day or night, circadian variations have been reported such that clusters are seen in the morning within a few hours of awakening. The most common presenting complaint, it occurs at rest, lasting more than 10 minutes. It is relatively recent onset within the prior 2 weeks. It occurs with a crescendo pattern, distinctly more severe, more prolonged, or frequent than previous episodes. Deep and visceral, heavy squeezing and crushing, stabbing, burning commonly occurs at rest. It usually more severe and lasts longer. Involves the central portion of the chest and the epigastrium and to the arms. Less common sites are like abdomen, back, lower jaw, neck, accompanied by weakness, sweating, diaphoresis, nausea, vomiting, anxiety, and a sense of impending doom. Pain may commence when the patient is at rest, but when it begins during a period of exertion, it does not usually subside with cessation of the activity, in contrast to the angina pectoris. The pain of STEMI, that is a ST-elevated myocardial infarction, can simulate pain from acute pericarditis, pulmonary embolism, acute aortic dissection, costochondritis, and GI disorder. The proportion of painless MI is greater in patients with diabetes mellitus and it increases with age. In the elderly, may present as sudden onset breathlessness, which may progress to pulmonary edema. Anginal equivalents, dyspnea, epigastric discomfort, nausea, or weakness may occur instead of chest pain and appear to be more frequent in women, elderly, and diabetic patients. If the patient has a large area of myocardial ischemia, it includes diaphoresis, paleness, cool skin, sinus tachycardia, S3S for basilar rails, and hypotension. Other less common presentations are maybe or without pain, sudden loss of consciousness, a confusional state, sensation of a profound weakness, or appearance of an arrhythmia, evidence of peripheral embolism, or an unexplained drop in arterial pressure. Pallor associated with perspiration and coolness of the extremities occurs commonly. Most patients are anxious and restless, attempting unsuccessfully to relieve the pain by moving about in a bed, altering their position and stretching. The combination of substernal chest pain persisting more than 30 minutes and diaphoresis, it strongly suggests MI. Although many patients have normal pulse rate and blood pressure within the first hour of STEMI, about one-fourth of the patients with anterior infarction have manifestations of sympathetic nervous system hyperactivity, which leads to tachycardia and or hypotension. And up to one half of the inferior infarction show evidence of parasympathetic hyperactivity, which leads to bradycardia and or hypotension. Migraine infarction progress through the temporal stages like acute, that is first few hours to 7 days, healing 7 days to 28 days, and healed more than 29 days. Laboratory findings, actually 4 groups of confirmation of myocardial infarction diagnosis. Electrocardiography, that is ECG, serum cardiac biomarkers, that is CKMB and troponin T and I, cardiac imaging, that is 2D echo, non-specific indices of tissue necrosis and inflammation like CRP. On the basis of ECG, there is a ST elevation in case of anterior leads, that is a V1, V2, V3 along with first and AVL leads, while for inferior leads there is a ST elevation prominently in a 2, 3 and AVF along with the reciprocal changes which occurs in a V2 to V4, while in anterolateral it is 1 and AVL and V4, V5, V6. These are classical ST elevations on the ECGs, while the serum cardiac biomarkers are proteins that are released from necrotic heart muscle after MI. Cardiac specific troponin T and troponin I, the preferred biochemical biomarkers for myocardial infarction. Levels may remain elevated for next 7 to 10 days after MI. CKMB. This is also a cardiac marker which rises within 4 to 8 hours and returns to normal by 48 to 72 hours. The drawback of CKMB is lack of specificity for STEMI, as CK may elevated with skeletal muscle disease or trauma in CKD patients, cardiac surgery, myocarditis, and cardioversion. The cardiac imaging is nothing but two-dimensional echocardiography. The ease and safety of the procedure make its use appealing as a screening tool in the emergency room. When the ECG is not a diagnostic of MI, early detection of the presence or absence of wall motion abnormalities by echocardiography can aid in a management to take a decision such as whether the patient should receive reperfusion therapy. Criteria for acute myocardial infarction. The term acute myocardial infarction should be used when there is evidence of myocardial necrosis in a clinical setting consisting with acute myocardial ischemia. Under this condition, any of the following criteria meets the diagnosis for MI, like detection of rise and fall of cardiac biomarkers values, preferably cardiac troponin, with at least one value above the 99th percentile upper reference limit and with at least one of the following, that is symptoms of ischemia, imaging evidence of new loss of myocardium or new regional wall motion abnormalities or identification of intrapulmonary thrombus by angiography. Other symptoms like new or presumed new significant ST segment changes, new onset left bundle branch block, development of pathological Q waves in the ECG. So troponin is also significant while and symptoms of ischemia along with ECG, it is preferably significant one in case of myocardial infarction. Cardiac death with symptoms suggestive of myocardial ischemia and presumed new ischemic ECG changes of new LBB, but death occurred before cardiac biomarkers were obtained or before cardiac biomarker values would be increased. Percutaneous coronary intervention related MI is arbitrarily defined by the elevation of cardiac troponin values more than 5 times in the patient with a normal baseline values or rise of troponin values more than 20 percentile above the baseline values. Symptoms suggestive of myocardial ischemias, new ischemic ECG changes, angiographic finding consisting with a procedural complication, imaging demonstration of new loss of viable myocardium, new regional wall motion abnormality is required. Stent thrombosis associated with MI when detected by coronary angiography or autopsy in the setting of myocardial ischemia. Criteria for prior myocardial infarction. Any one of the following criteria meets the diagnosis for prior myocardial infarction, that is pathological Q waves with or without symptoms in the absence of non-ischemic causes, imaging evidence of region of loss of viable myocardium that is thin and fails to contract in the absence of non-ischemic causes, pathological findings of prior MI, the initial management. Pre-hospital care. Major elements of pre-hospital care in a suspected MI are recognition of symptoms and prompt seeking of medical attention. Rapid deployment of an emergency medical team capable of performing resuscitative maneuvers including defibrillation. Expeditious transportation of the patient to a hospital facility that is continuously staffed by physicians and nurses skilled in managing arrhythmias and providing advanced cardiac life support. Expeditious implementation of reperfusion therapy. Elevation MI in initial management. Initially presentation of symptoms, then we have to call the emergency, that is ambulance, then that emergency medicine services where which are in an ambulance which gives encourage 12 lead ECG, pre-hospital fibrinolytic therapy if capable, that is dual to needle within 30 minutes. Goal is restoration of adequate myocardial perfusion and lysis of the clot within 30 to 90 minutes. If after this pre-management, if patient comes to hospital, that is after emergency triage plan, if PCI is capable or not capable, it depends on the hospital facilities. Then hospital fibrinolysis therapy, that is dual to needle within 30 minutes and intra-hospital transfer for PCI. Fibrinolytic agents converts plasminogen to plasmin, which subsequently lyses fibrin thrombin. Non-ST elevation MI, unstable angina, initial management. Fibrinolytic therapy not indicated for non-STEMI and unstable angina. Antithrombotic agents are required in this, that is antiplatelets like aspirin, clopidogrel, prasugrel, anticoagulants like heparin, warfarin. Difference between management of ST elevated myocardial infarction and non-STEMI or unstable angina. The primary tool for screening patients and making triage decision is the initial 12 lead ECG. When ST segment elevation of the at least 2 mm in two contiguous precordial leads and 1 mm into adjacent limb leads is present, the patient is candidate for fibrinolysis or PCI. In the absence of ST segment elevation, fibrinolysis is not helpful and evidence exists suggesting that it may be harmful. That is, statement is applicable for non-STEMI unstable angina. We don't have to lyse in this scenario. Emergency department management, that is the goals, control of cardiac discomfort, rapid identification of patients who are candidates for urgent reperfusion therapy, triage of lower risk patients to the appropriate location in the hospital, avoidance of inappropriate discharge of patients with MI. Initial medications are antiplatelets like aspirin and clopidogrel, anticoagulations like unfractionated heparin, low molecular weight heparin. Control of pain and discomfort, we can use nitrates, beta blockers, morphine. Reperfusion therapy for STEMI, they mostly accelerates the opening of infarct related arteries. Timely restoration of flow in the epicardial infarct related artery combined with improved perfusion of the downstream zone of infarcted myocardium results in a limitation of infarct size. Fibrinolytic drugs and percutaneous coronary intervention. What is the fibrinolytic therapy? It should be ideally be initiated with 30 minutes of presentation, like door to needle time is less than 30 minutes. Principal goal, prompt restoration of full coronary arterial patency. The agents which are used for fibrinolysis are tissue plasminogen activator, streptokinase, tenecteplase, reteplase, that mostly converts of plasminogen to plasmin, which subsequently lyses fibrin thrombi. What are the contraindication for this? There are two types again, clear contraindication and radio contraindication. Clear contraindications are history of cerebrovascular hemorrhage at any time, non-hemorrhagic stroke or other cerebrovascular accident within past year, mark hypertension, that is more than 180 mm of Hg systolic and diastolic more than 110 mm of Hg. suspicion of aortic dissection, active internal bleeding, excluding menses. While relative contraindications are INR is more than 2, current use of anticoagulants, a recent that is less than 2 weeks invasive or surgical procedure, prolonged that is more than 10 minutes of CPR, pregnancy, non-bleeding diathesis, a hemorrhagic ophthalmic condition, active peptic ulcer disease, history of severe hypertension that is currently controlled one. Patient should not receive streptokinase if that agent had been received within preceding 5 days to 2 years. Thrombolysis in myocardial infarction, that is called as TIMI, it depends on the grading system like grade 0, complete occlusion of infarct related artery. Grade 1, some penetration of the contrast material beyond the point of obstruction but without perfusion to the distal coronary bed. Grade 2, perfusion of the entire infarct vessel into the distal bed but with flow that is delayed compared with that of coronary artery. Grade 3 is a full perfusion of the infarct vessel with normal flow. Cardiac catheterization and coronary angiography should be carried out after fibratic therapy if there is evidence of either, that is failure of reperfusion, coronary artery reocclusion, that is a re-ST segment elevation or recurrent chest pain or the development of recurrent ischemia. Coronary Care Unit Management, that is CCU. These units are routinely equipped with system that permits continuous monitoring of the cardiac rhythm of each patient and hemodynamic monitoring in a selected patients. Defibrillators, respirators, non-invasive transthoracic pacemakers, facilities for introducing pacing catheters and flow dilated balloon tip catheter. Patients should be admitted to a coronary care unit. The lower risk patients, that is not hemodynamically compromised and without active arrhythmias, to intermediate care units. If symptoms are controlled with oral therapy, patients may be transferred out of the ICU, may be safely transferred within 24 hours. Also, for patients who have confirmed STEMI but who are considered to be at low risk, that is no prior infarction, no persistent chest discomfort, congestive heart failure, hypertension or cardiac arrhythmias. Activity factors that increase the work of the heart during the initial hours of infarction may increase the size of the infarct. Patients with STEMI should be kept at bed rest for the first 6 to 12 hours. In the absence of complications, patients should be encouraged under supervision to resume an upright posture by dangling their feet over the side of the bed and sitting in a chair within the first 24 hours. In the absence of hypotension and other complications, by the second or third day, patient typically ambulating in their room with increasing duration and frequency, and they may shower or stand at the sink to bath. By the end third day of infarction, patients should be increasing their ambulation progressively to a goal of 185 meters, that is approximately 600 feet at least 3 times a day. Now pharmacotherapy. Antithrombotic agents. Primary goal, it is to maintain patency of the infarct related artery in conjunction with reperfusion strategies. Secondary goal is to reduce the patient's tendency of thrombosis and thus the likelihood of mural thrombosis formation or deep vein thrombosis, either of which could result in a pulmonary embolization. Clinical use of antithrombotic therapy, oral antiplatelet therapy like aspirin, clopidogrel, prasugrel, ticagrelor, which should be used. Intravenous antiplatelet therapy like iptifibatide, tirofiban, abeximab. These are all according to on the basis of weight we have to give dosage. Heparin, specifically unfractionated heparin and fractionated heparin like fondaparinux, enoxaparin, beoladin. Now antiplatelets. Aspirin, the standard antiplatelet agents. Mechanism of action is nothing but rapid inhibition of cyclooxygenase 1 and platelets followed by reduction of thromboxane A2. Buccal absorption of a chewed near about 300 to 325 milligram of tablets followed by a daily oral administration of aspirin in the dose of 75 milligram to 162 milligram. Clopidogrel, prasugrel and ticagrelor, glycoprotein 2B3A receptor inhibitors. Anticoagulants like an unfractionated heparin, the standard anticoagulant agent. Monitor the activated partial thromboplastin time. It should be 1.5 to 2 times the control value. Low molecular weight heparin like enoxaparin, factor 10 inhibitor like fondapainox, diet antithrombin that is bivalirudin. Second type is anti-ischemic therapy to provide relief and prevention of recurrence of chest pain. Initial treatments are bed rest, nitrates, beta blockers, and inhaled oxygen in the presence of hypoxemia. Anti-ischemic treatment specifically, also we can give a trial of calcium channel blockers, morphine, a patient whose symptoms are not relieved after 3 serial sublingual nitroglycerin tablets, whose symptoms recur with adequate anti-ischemic therapy. The side effects or when should be avoided like hypotension, we not use morphine. Control of discomfort. Nitroglycerin decrease myocardial oxygen demand by lowering preload and increasing myocardial oxygen supply by dilating infarct-related coronary vessel or collateral vessels. 0.4 milligram sublingually within a duration of 5 minutes. We can raise or we can give 3 times in a day. IV nitroglycerin we can also use if accompanied by other evidence of ongoing ischemia such as further ST segment elevation. T-wave shifts avoided in a patient whose present systolic BP is less than 90 mm of Hg or in home where it is clinical suspicion of right ventricular infarction. Morphine, it is very effective analgesic for the pain. Intravenous injection of small doses like 2 to 4 mg within 5 minutes, but reduce sympathetically mediated anterior and venous constriction, resulting venous pooling and may reduce cardiac output and arterial pressure. Has a vagotonic effect and may cause bradycardia or advanced degrees of heart block. Now, after this, we can use beta blocker, like which diminishes myocardial O2 demand, reduce the risk of reinfarction and ventricular fibrillations. Beta blockers like metoprolol, 5 mg, we can give by within 2 to 5 minutes, next 3 doses, and the patient has heart rate more than 60. Systolic pressure more than 100 and PR interval is less than 0.24 second and the rails that are more than 10 centimeter from the diaphragm. 15 minutes after the last IV dose, an oral regimen is initiated of 50 mg 6 hourly for first 14 hours, followed by 100 mg 12 hourly. Inhibition of the renin angiotensin aldosterone system. Angiotensin receptor blockers like ARBs mechanism involves reduction in ventricular remodeling after infarction with a subsequent reduction in the risk of congestive heart failure. Should be continued indefinitely in patients who have clinically evident of congestive heart failure. In patients in a imaging study shows reduction in a global LV function or a large regional wall motion abnormality, or in those who are hypertensive. Ventricular dysfunctions. After STEMI, the left ventricle undergoes a series of changes in shape, size, thickness in both the infarcted and non-infarcted segments. That is nothing but ventricular remodeling. Soon after STEMI, the left ventricle begins to dilate. Acutely, this results from expansion of the infarct, that is a slippage of muscle bundles, disruption of normal myocardial cells, and tissue loss within a necrotic zone, resulting a disproportionate thinning and elongation of the infarct zone. Second is a pump failure. Now the primary cause of in a hospital death from STEMI is a pump failure. The most common clinical signs are pulmonary, rales, and H3S4 gallop sounds. Elevated left ventricular feeling pressure and elevated pulmonary artery pressure are the characteristic hemodynamic findings, but these findings may result from a reduction of ventricular compliance. That is a diastolic failure and reduction of stroke volume with a secondary cardiac dilation, that is a systemic failure. Hypovolemia, it may be a secondary to previous diuretic used to reduce fluid intake during the early stages of the illness and vomiting associated with the pain or medications. Cardiogenic shock. Only 10% of the patients with this condition present with on admission, while 90% develop it during hospitalization. Right ventricular infarction, and sixth complication is arrhythmias. The mechanism behind the arrhythmias are autonomic nervous system imbalance, electrolytic disturbance, ischemia, slowed conduction in zones of ischemic myocardium, ventricular premature beats, ventricular tachycardia, ventricular fibrillation, sustained ventricular tachycardia. Other complications like pericarditis, pericardial friction rubs, or pericardial pain are frequently encountered in patients with STEMI involving the epicardium. Complaints of pain radiating to either trapezius muscle. Thromboembolism considered to be an important contributing cause of death in 25% of the patients with STEMI who die after admission to the hospital. Arterial emboli originate from left ventricular mural thrombi, while most pulmonary emboli arise in the leg veins. Long-term management. Risk factor modification is a key. Smoking cessation, achieving an optimal weight, daily exercise, blood pressure control, follow an appropriate diet, control of hyperglycemia in a diabetic patient, and lipid management. Thank you.